So here are my objectives. It's really to cover treatment options for patients with kidney failure. And it's our hope that many of you, or at least some of you, will actually never get to kidney failure and need to consider these options. But that's my goal. So I'm going to talk briefly about evaluating patients for a kidney transplant. I'm going to cover when eculizumab should be used, but it's really only in the transplant setting. Dr. Nestor probably covered much of eculizumab use outside of the transplant setting. How should eculizumab be monitored? Can eculizumab be stopped? And I know Dr. Nestor got that question too. And what if transplant is not an option? That is, for patients who have kidney failure, there may be reasons why they may not be able to get a kidney transplant. And therefore, in the interest of covering management of kidney failure, I ought to cover that as well. Okay, so very briefly, the ways that one can treat atypical HUS are with plasma, either as plasma infusion or plasma exchange. And that's still an option for patients who have atypical HUS, either as the disease begins, before it's become apparent what the disease is, or at times when eculizumab may not necessarily be the best drug to use, but for example, during, say, pregnancy, or in a patient who might have a severe allergic reaction to eculizumab, or in parts of the world, including the US, where eculizumab may not be easily available or affordable. Plasma therapy is still a very reasonable option. And there may be types of mutations of atypical HUS that we are yet to recognize that might not respond to eculizumab. And then there's eculizumab that many of you already know about. I've mentioned here liver transplantation. This is a liver transplant without a kidney transplant early in the disease, before one actually gets kidney disease, as a way, if you will, to permanently cure atypical HUS, because some types of atypical HUS that arises from mutations in proteins that the liver makes, you can then restore a person to, if you will, a full cure with a liver transplant. And I'm not going to speak much more about it, but other than to cover it as a possible option for treatment of the disease. And then I put a question mark against other, and these would be other drugs that are in the pipeline that would treat atypical HUS of the standard form, that is the one that is associated with alternate pathway complement activation. So it would be other drugs that block terminal complement. And there are other drugs that are in development that might attack, say, the coagulation pathway, the clotting cascade, that might be operative in some forms of atypical HUS. And that for now is not really available, but it may be in the future. So what about the person who has advanced kidney disease, what we call CKD, as a broad term to cover patients who have kidney disease that is recognizable? And we used to use the term kidney failure. We don't use kidney failure anymore. We call it CKD. Before they need to have dialysis or they need a transplant, and once they get to needing dialysis or a transplant, then we say you have end-stage renal disease or end-stage kidney disease. And if it's a very advanced stage of chronic kidney disease, we give it staging based on how bad your kidney function is. And typically, before you need to start dialysis or get a transplant, you are CKD stage 5. So the treatment options then are to give you a kidney transplant with standard therapy, and that means the standard treatment cocktail, including drugs that suppress your immune system, but not including eculizumab. That's what I mean by standard therapy. One can consider a liver with a kidney transplant and kidney transplant with eculizumab or dialysis. These are the 4 options available for a person who is approaching dialysis or is already on dialysis and needs some form of renal replacement therapy. So starting then with kidney transplant alone, that is without eculizumab, and this is likely to succeed in some patients. Those patients that have mutations that are actually within the kidney itself. For example, a protein called MCP is found in the kidney, not in the liver. And therefore, if you get kidney failure with atypical HUS from this protein, it's not because it's a circulating protein made by another organ, but it's because the kidney itself makes this protein and it's somehow defective in a patient with this mutation. So in that circumstance, if you were to then give a person a new kidney that does not carry this mutation, there is a high likelihood that that kidney will work just fine, although all of the usual issues that occur with kidney transplant patients will still be there. But in terms of recurrence of atypical HUS, that is not likely to be there. But yet I've told you that the recurrence risk isn't zero, it's 0 to 15%. And why might that be? Well, it could be because we don't necessarily identify all the mutations that a person may have. So we might recognize MCP mutations in a patient, but miss another mutation in a different gene that we didn't realize. Or it could be because we have now taken a kidney from a person biologically related to that candidate who needs a kidney, who might in fact also have that MCP mutation. But chances are, if that's the only mutation and it's not from someone biologically related, that it should be a 100% relapse or recurrence-free situation. In other situations where the mutations are in genes that are not expressed in the kidney but are expressed in other organs, such as the liver, there's a very high likelihood of failure of the kidney transplant if it is done without eculizumab or without a concurrent liver transplant. And the examples I've given there are the ones that we have the most experience with: complement factor H and complement factor I. They're also the more common mutations that cause atypical HUS, and these do have a very high rate of recurrence, as much as 90% for H and as much as 85% for I. And so that's something to keep in mind if one has to approach a kidney transplant without the option of using eculizumab. What about a kidney and a liver transplant combined? Now, when the planned treatment for atypical HUS with kidney failure first began, and this was before eculizumab was available, a liver kidney transplant was the first attempt, if you will, to permanently address the problem of recurrent disease. And there are some pros that I want to discuss as well as the cons. One is that it offers a potential cure for factor H and for other proteins that might be made in the liver, factor B and C3 deficiency, for example. And we have the most experience, not we as in Iowa, but we globally have the most experience with factor H. And it clearly appears to be beneficial in that circumstance. It's been tried for factor B and C3 deficiency, but it's not yet clear whether it's going to be useful in that circumstance. And there's an unclear benefit if the problem is not a simple deficiency of a protein that the liver makes. Sometimes a mutation in a protein doesn't just make it deficient in its action. It might acquire a new function, in the sense that that defective protein now counteracts or inhibits the function of the other normal copy of that protein. So factor B, for example, it typically is present in two copies because one gets a chromosome from dad and one gets a chromosome from mom. And if you have a mutation in factor B that reduces the amount of available factor B by 50%, you get disease from deficiency. But if that deficient protein also now has the function of inhibiting the other copy of factor B, now you can get a problem with a circulating protein that is itself damaging, and giving a new liver may not necessarily correct it if that deficient protein is also made by other organs that could be circulating. Sometimes you can have atypical HUS from antibodies that can inhibit the function of complement, and that too may not necessarily be treated by a liver transplant alone. But a liver transplant avoids the need for long-term eculizumab. It may help patients who have HLA antibodies. So HLA antibodies are antibodies that I make against all of you in the room if I were to be exposed to your tissues or your blood. It's the proteins that define who we are and makes me different from him. And when we see proteins from other people in the form of a transfusion or a pregnancy or another transplant of one sort or another, we make antibodies to other people's proteins, and those are called the HLA antibodies. And for those of you who have HLA antibodies, this can be a problem in getting you a kidney transplant alone, whether or not you're going to get eculizumab. If you were to get a liver with a kidney, that tends to help patients who have HLA antibodies. The liver somehow protects the kidney from being attacked by HLA antibodies. The other, and this is a very practical matter, and that is that in patients who don't have a living donor, who may otherwise have a long wait for a kidney transplant alone, getting a liver with a kidney will shorten that waiting time, because that's how organ allocation rules are written in the country. And so people who qualify for a liver transplant, and this includes patients with some atypical HUS mutations, will get fairly high up on the liver transplant waiting list and will get a kidney when they get a liver. So the waiting time for a liver kidney together may in fact be shorter than a kidney transplant alone for those that have a lot of HLA antibodies, who don't have a living donor, or who might have a blood type that may make it more difficult to get a kidney transplant in a timely fashion. And then there is the possibility of having a pregnancy without eculizumab. And I'll get back to the pregnancy question since somebody brought that up in the questions that were submitted to me. Okay, the cons for a combined kidney liver transplant are this. One is that it's a much bigger operation, and the operative risks are much higher than a kidney transplant alone. And we, I think globally, probably have done 20, 25, 30 combined kidney liver transplants. That's not a whole lot of experience, and the early experience was fraught with a lot of complications, but the experience has improved, and now it is much better with the use of plasma and the use of perioperative eculizumab. So this is not long-term eculizumab, just during the operative period. The risks are still higher, and it's still, if you will, restricted to just a handful of centers. It's unclear if this big operation really offers any advantage over doing a kidney with eculizumab alone, if eculizumab is readily available and is going to be around forever. The other problem is that a liver transplant does not last forever, and in a young person who gets a combined liver kidney transplant, several years down the road, 10, 20, 30 years down the road, one might need another liver transplant, because all transplanted organs, regardless of why they were given, will tend to fail eventually. And there are a number of reasons for this. And when that liver transplant eventually fails, the special exception points one got to get the liver during the time that you had atypical HUS might not be around to help you get another liver transplant if you needed it. Now this is all theoretical, because that's several years down the road and the rules may change, but that's something again to keep in mind.
You feel like if you add up all the side effects about the anti-rejection drugs you're taking for the liver, even though it's, quote, a cure, don't those side effects and all those meds you got to take a lot harder than just taking eculizumab?
Well, so yes, it is, but we're talking here about a liver kidney versus a kidney alone. So in terms of the immunosuppressive medications that one has to take to maintain the transplanted organ or organs, they are the same. In fact, in general, the liver transplant recipient, whether or not he or she gets a kidney together with that liver, tends to be on somewhat lower amounts of immunosuppressive medications. So you will not necessarily be exposed to additional potentially severe side effects of drugs that you may get with the liver that you wouldn't see with a kidney transplant. Does that answer your question?
Yes.
Okay, so that leaves what for us is the preferred option, which is a kidney transplant with eculizumab. There's a high likelihood of success, and this is based on our experience and on published literature that is now accumulating every month. And it's, I think, the the best way to do this, and I'd say strongly recommended for some type of mutations, the ones that we have the most experience with, which is complement factor H and complement factor I, and putting somebody on eculizumab at the time of their transplant and committing them to long-term therapy does not preclude the subsequent consideration of withdrawal of eculizumab. And giving somebody a kidney transplant alone with eculizumab does not preclude the subsequent consideration of adding a liver transplant if you were to get to that point. And I think this is something that has become more apparent recently. Eculizumab has other benefits in patients who need a kidney transplant, and that is it appears to reduce the damage caused by other antibodies, such as HLA antibodies that you might have had before you got your kidney transplant or you acquired after you were exposed to that kidney transplant. And those HLA antibodies can cause a form of rejection we call antibody-mediated rejection, which is not easy to treat. And this drug, eculizumab, by blocking the antibody-mediated damage of the transplanted organ, in this particular case the kidney, tends to protect it. And we have at least 2 patients who've had high levels of antibodies in their system going into their kidney transplant who've done extremely well. And I suspect it's because they're getting eculizumab for another indication. And so that's another potential benefit, but that's really not an indicated reason currently. So as I said, our recommendation would be to do a kidney transplant with preemptive, meaning starting before the transplant, perioperative, meaning around the time of the transplant, and long-term use of eculizumab. So how do we approach patients who come to us referred for a kidney transplant? Well, the first thing that we have to do sometimes they come all wrapped up with a neat bow and a nice diagnosis, and all the tests have been done. But that's not necessarily always the case. So we then first have to make a formal diagnosis, which means differentiating it from other diseases that can look the same. And I've given you some examples, TTP, the other form of aHUS. And we do this by taking a careful history, going back through the entire record, reviewing their prior kidney biopsies, if those exist, and then screening for mutations in genes that are known to cause atypical HUS. And that list of mutations is actually growing. And there may come a point where it becomes counterproductive to screen for all of them, but for now we are doing that. We can actually measure the amount or the abundance of some of these proteins in the bloodstream. We can look for autoantibodies, and we can look for activity of other proteins that might impact this disease or may actually be contributing to a different disease that looks like this. And once we've made a diagnosis and are comfortable with where we are, then we would consider our treatment options, which is the standard treatment option with a kidney transplant alone if you had a mutation in MCP, and a living unrelated kidney transplant with eculizumab for patients with most mutations. And for those whose disease is uncharacterized, meaning we believe clinically it's atypical HUS, but we haven't found the smoking gun that confirms that that's what it is. And for patients that might have autoantibodies that are causing atypical HUS. In all of those patients, living unrelated kidney transplant is the preferred way for us to approach a person who might need a kidney transplant. If it's a living related donor, and by related here I mean biologically related, not the spousal relation but the other, then we would advise strongly that the donor should be screened for mutations that cause atypical HUS. Our own preference is to not take any biologically related donor because the list of mutations are getting longer and longer, and because identification of one mutation in one gene does not mean that there is no other genes that might be mutated. And because of that uncertainty, especially when it's a biologically related younger person, a sibling or a child, out of an abundance of caution, we have advised strongly that we would not want to consider such a living donor. Okay, so then the standard plan of action, assuming they have not yet been on eculizumab, is first immunize against meningococcus, at least 2 months prior to starting eculizumab, and the reason for that 2 months, which is much shorter than what the FDA requires, sorry, much longer than what the FDA requires for meningococcal vaccination, is that patients that have kidney disease do not necessarily mount a strong antibody response when they are vaccinated. And the second is that we really ought to get 2 vaccinations in to assure us of the best chance of mounting an adequate immune response. So 2 months really is the ideal time, and typically in these situations a living unrelated kidney transplant is a planned procedure, and we do have that time. More often than not, patients are now coming fully vaccinated, so that's not an issue. If it's a living donor, we need to make sure that that donor is not at excessive risk for atypical HUS and for a lot of other diseases that people get. So part of our evaluation plan for any living donor is to do our due diligence by making sure that they're not at risk for other types of kidney disease that might arise because of their particular family history, that might arise because of their risk of getting diabetes, and so on and so forth. So approximately 90% of living donors that present to an institution as potential candidates for transplantation are declined because of issues that we identify or they identify as posing an excessive risk to being a kidney donor. And then if one has a living donor and the recipient is naive to eculizumab, then what we would do is give eculizumab 1 week prior to transplant. We, in the beginning, were doing plasma exchange. This is probably not necessary anymore, but when we began to use this drug, it had not yet been FDA approved, and there was very little experience with it. And we give a second dose of eculizumab just prior to surgery. If it's a deceased donor who has not previously had eculizumab, we would give the first dose just prior to the transplant and the second dose the day after. And then the maintenance dose is, as you're probably all familiar with. So the major issues with eculizumab then are meningococcal infection, as you're all aware, and that's why the vaccination prior to therapy. In our institution, we recommend long-term antibiotics even for those that are vaccinated, and I know that there are different practices in the US and in Europe. The hematologists here who've been treating the other disease for which eculizumab is used do not routinely use long-term antibiotics. The Europeans do routinely use long-term antibiotics, and the reasons are that, one, vaccinations do not result in 100% immunity. The second is the vaccinations do not cover all of the strains of meningococcus that can cause disease today. The vaccine is developed against some strains, but not all. And there have been rare cases where people vaccinated against the meningococcal vaccine have developed meningococcal disease. So our approach has been to take the European approach and to use long-term antibiotics. Not that that's necessarily a benign approach, because every drug has side effects, but so far, touch wood, that strategy seems to have worked for us. There's the issue of the expense and insurance coverage, and I know that this will continue to be a struggle not only in the US but in parts of the world where this drug is way too expensive and where priorities have to be made in terms of population health. One of the questions that came up had to do with pregnancy. Can eculizumab be used during pregnancy? And here's what we know. We know that some patients have been pregnant on eculizumab. There's probably 12 to 15 case reports of patients on eculizumab, and there have been no major side effects of the drug that was attributable during pregnancy that had an impact on the baby. Only 2 or 3 of that 12 actually got eculizumab from conception to delivery. many of the other 12 actually got their eculizumab fairly late in the disease, and there are various vulnerable times for a baby in terms of exposure to drugs. So the literature seems to suggest that it can be used and it is probably safe, but it's an extremely limited experience. The FDA labels this drug as category C in terms of pregnancy risk, which means that the physician and the patient have to consider the risk and use it only if the benefits outweigh the risks. That, by the way, is the same category of risk as the drug tacrolimus that we use routinely to maintain a transplant during pregnancy and have not really felt the need to discontinue it. Now, you could, if you will, debate the issue of the benefit of a pregnancy versus not, but I'm not going to get into that debate. What you should know is that while 3-4 years ago we were very reluctant to consider pregnancy, if this was something that someone wanted to consider, we would be open to it. There are some challenges of using eculizumab during pregnancy, in addition to the fact that there's very limited information on the drug. There is a clear suggestion that the needs for eculizumab will likely increase during pregnancy because of alterations in what happens to mom during pregnancy. And so if that's going to be considered, well, there has to be very careful monitoring of eculizumab levels and or the effect on complement blockade so that the appropriate dose of eculizumab is being used. And obviously, in anybody who's considering a pregnancy, whether it is with atypical HUS or any other disease, if they've had a kidney transplant, they ought to see high-risk obstetrics before conception, that is, while they're planning a pregnancy, and see their transplant physician so that all of the drugs that they're on can be reviewed. It's not just eculizumab that may have an impact on pregnancy. There's many, many drugs that can have an impact, and some of them we adjust, reduce, drop, or eliminate altogether when a person is planning a pregnancy. How long to use eculizumab? I think Dr. Nestor covered this. Our own approach for now has been to use it forever. But there will come a time when somebody somewhere who controls the cost of the drug will say no. And we will have to face that situation. We haven't got to that point yet. Can we tailor therapy? That is, can we continue the drug but use less of it? I think the answer is yes, and Dr. Nestor and I are not necessarily fully agreed on this, but I think we can tailor the therapy. The drug dose that the FDA has approved is what was tried and tested in clinical trials, so we know that that dose works. But I think there are some patients who can probably get away with less drug or less often, because that drug, like every drug we use, tends to have different levels of activity in different people based on their own genetic makeup, based on other drugs they may take. And so not everybody is created equal. And so I think there may be situations where we can consider reducing the dose and or the frequency of a drug. But it's those circumstances where a person needs to be extremely carefully followed. If one is going to stay on the standard dose of drug and there is, if you will, no concern about supply and no intercurrent infections, no pregnancy, no surgical episode that might alter your complement balance, then you can just keep taking eculizumab at the full dose every 2 weeks and just forget about it, really. But when one is considering tailoring therapy, then we have to pay special attention, because now you're sort of tinkering with something that works in the belief that you can tinker, but has to be very carefully monitored. So some special considerations for transplant patients. This applies to all kidney transplant patients, not just atypical HUS. That is the problem of HLA antibodies. And so to the extent possible, you would want to avoid a blood transfusion, but you don't have to avoid a pregnancy or a transplant if you need it. But one of the consequences of having a transplant or a pregnancy is that you can develop antibodies to other people's tissues. And in the case of a pregnancy, what you're doing is really developing antibodies against that portion of the baby that came from the father, which will mean that some fraction of the population is now out of bounds for you because you may react to those kidneys. I already talked about planning a pregnancy. There's a risk of infections. Eculizumab is a drug that weakens or suppresses your immune system. The fact that you have to be particularly watchful for a serious infection is an example of why eculizumab is an immunosuppressive medication. We use some other immunosuppressive medications after a transplant, which have its own consequences for infection risk and risk of other diseases that has to be kept in mind. And then there is the role of bilateral nephrectomy. So this was the practice, if you will, of removing one's own kidneys prior to getting a kidney transplant for certain diseases. Atypical HUS used to be one of those diseases where blood pressure used to be difficult to control and was at least partly attributed to the presence of those own or native kidneys. And so those were removed at some centers prior to a transplant. I don't think there's any role for those anymore. And even though those kidneys are not really working satisfactorily, they still have a little bit of function, and if they can stay in, they ought to stay in. And besides, taking it out is a pretty big operation. So getting back to tailoring therapy, so if one is going to do this, you would want to be following kidney function, and probably the most sensitive kidney function one can monitor for disease activity is to look for red cells in the urine. You can do this with a simple dipstick that people can learn to do if they haven't already learned. And we measure this blood protein or blood factor called creatinine, which is a simple measure of kidney function. We look for parameters of hemolysis. Some of you are probably already familiar with these terms. Obviously, the hemoglobin, which gives us a measure of the level of blood red cell production, haptoglobin, LDH, and platelets. And we can monitor for the effectiveness of the drug we use in terms of its complement blockade. We can measure functional C5 levels. We can look at total hemolytic complement. We can look at soluble complement, terminal complement cascade activity. And there's a new test that's been described by the Italian group called the endothelial C5b9 deposition that may also turn out to be useful. So there are ways to monitor this disease and the drug that's being used to treat it. So can eculizumab be stopped? So here's what I can tell you from what the published studies tell us. That is that before and after a transplant, relapse of atypical HUS is not predictable. We know, as best as we know, the disease stays in remission with eculizumab. At least that's what the published reports tell us, with perhaps one or two exceptions. We also know that when the disease is recognized late and eculizumab is started late, that it does not necessarily reverse the disease process. And because some physicians and patients have tried to carefully stop the drug while under close monitoring, we know that under those circumstances, the disease has recurred in a high percentage of patients within weeks or months. This is particularly true for complement factor H. And what is evident from the published studies where this was carefully done is in patients who carefully tracked their urine for blood and where their kidney function was carefully tracked in the lab, the first sign of disease recurrence prompted the reinstitution of eculizumab, and the disease stayed in remission, if you will. So it can be done, but it has to be done extremely cautiously, with full knowledge by the patient that there may actually be a relapse and that there may be a situation where the relapse happens so fast that might not get to it. So you couldn't, for example, do something like that and then travel to Africa on a safari, because then you'll be someplace far away and might not be able to get back here. So what don't the studies tell us? So remember that when we find something that we believe is informative for the scientific community at large, we try and disseminate that information in the form of publications, scientific publications. What we then have is something called publication bias. So if a drug doesn't work as expected, if there's an unusual side effect, or if it's same old, that important piece of information may not get disseminated, and that's called publication bias. So we don't know how many patients, for example, responded well without eculizumab, with plasma exchange or plasma infusion. We always hear about the recurrences. And we don't know how many aHUS patients did not respond to eculizumab. I suspect that would have been published if that happened. And we don't know whether there's long-term concerns with the use of eculizumab. My belief is that it's likely to remain as a safe drug, barring the effect on complement and the resulting consequences for infections. But as the spectrum of diseases for which we can use eculizumab become broadened, it will become apparent that eculizumab has functions beyond just blocking complement in atypical HUS. And then there is the obvious question, since we're using eculizumab, are there more infections that we are likely to see with eculizumab beyond meningococcus? And we don't know the answer to that. We have seen 1 or 2 patients who've been transplanted who've had eculizumab plus the standard cocktail of immunosuppressive medications get an unusual viral infection that perhaps was because of the combination, but we don't know that for sure. So also briefly then, what if transplantation is not an option? In general, transplantation is superior to dialysis for those that need one or the other. It ensures a longer survival, it's a better quality of life. There are no dietary or fluid restrictions. For those of you who are on dialysis or who have been on dialysis know what this is about. There's better blood pressure control. There's the ability to conceive, which is substantially enhanced by having normal kidney function. There's enhanced productivity in every sense of the word, being able to return to the workplace, or if you're a child, to get, to be in the playground and have the energy to do what you want to do and hang out with your peers. And obviously growth and maturation is an issue for children and young adolescents. So if the kidney transplant is the ideal therapy, why don't we offer this to everybody? The problem is that there are way too many candidates that need a kidney transplant and not enough organs. And so what this tells you is that, so this is the rate of kidney disease in the US population, per million population. Here is the timeline, 1988 to 2010. So that's about a 25-year period. You can see, if you follow this olive green line, this was the incidence of kidney failure in 1988, and this is where it is today. It has more than doubled. And as a consequence, because the number of kidney transplants has not changed, when you look at the number of kidney transplants factored for the need, that's the number of patients who need it, that has dropped as a rate. And what that means then is that if you look at this same timeline and just focus on these 2 lines and ignore the one on top and the one below, the waiting list back in 1988 was 10,000 patients. That waiting list today is, this is actually 2010, is about 80,000. Today it's over 100,000 patients who are waiting for a kidney transplant. And if the waiting list is growing, that must mean that the waiting time is increasing. So the median waiting time used to be about 1 year. Today it's 4 years. If you have blood type B and you don't have a living donor, that waiting time, that median waiting time is closer to 6 years. If you live in some parts of the country where there's a greater demand, then the waiting time could be even longer. If you had HLA antibodies that impacted your access to transplant, that gives you a longer waiting time too. So there are many reasons why transplantation may not be an immediate option for those that deserve to have it. So here is, if you will, the number of kidney transplant people on the waiting list again as of 2010. The number of living donors is down here. The number of deceased donors are down here. And you can see that this has remained fairly static or constant, while this line has continued to rise almost meteorically. And there are geographic disparities in how kidneys are transplanted. That's an unfortunate fate of geography, if you will. And this is just an example of how the waiting time differs in different parts of the country. And so the darker you get, the better off you are, meaning this is the percentage of patients who get a transplant within 5 years. And you can see that some parts of the country, the fraction that get a transplant within 5 years is much lower than in some other parts of the country. And that's just a reflection of the incidence of kidney disease, the number of deceased donor organs that become available, and the territory through which those organs have to be distributed. So if you can't get a kidney transplant, then as a nephrologist, I would say that the best way to have dialysis is some form of continuous or more frequent dialysis. And today, the data would suggest that some form of daily hemodialysis is probably the best way to be on dialysis, either while waiting for a transplant or if transplant isn't an option. And this is really just to show you that the outcomes for patients on daily dialysis is the same as those who get a deceased donor transplant. And there are two forms of daily dialysis. There is a form where you can do daily nocturnal dialysis, which is long dialysis every night, or daily short during the day dialysis, which is 2 to 3 hours every day, or at least 5 to 6 days out of a 7-day period. Okay, so I'm going to stop there and very briefly summarize. Early recognition and prompt treatment of atypical HUS may reduce the incidence of kidney failure, and at some point in the future I might not even have to stand here and talk again because there will be no patients who may need a kidney transplant. I think that's unlikely because some patients will present extremely late in the disease because they don't have the warning signs that indicate they have atypical HUS or that they have early kidney failure. But the number of patients who might get to this stage will certainly fall with time, especially if the drug is readily available. For patients with end-stage renal disease, a living unrelated donor kidney transplant is the preferred way to treat end-stage renal disease. With some exceptions, the transplant should be performed with perioperative use of eculizumab, which should be continued long-term. Patients should be monitored carefully for disease recurrence, especially if they're not on chronic standard dose eculizumab therapy.